Hi, my name is Nick Kuntz. I'm a neuroradiologist and head and neck imager at Mayo Clinic in Arizona. And today I'm going to be talking to you about oral cavity cancer in this talk that's entitled Imaging Approach and Key Diagnostic Points. I have no financial disclosures. So here's the goals of today's talk. I'll start off by talking a bit briefly about some key epidemiologic factors that are associated with oral cavity cancer. We'll move next into probably the, boring, slightly painful portion of this lecture, which is going to be talking about the staging of oral cavity cancer. If you love staging head and neck cancer, then maybe you'll love this. But, to me, it's a little bit tedious, but it's really important stuff. And I think it's something that we all need to have an appreciation for the important details that need to be reported so that we can come to an appropriate stage. And then we'll move on to a little bit more exciting topics. We'll talk about imaging anatomy of the oral cavity. Then we'll talk about different multimodality strategies for imaging of oral cavity cancer. And then the last part of the talk, we'll go through each of the important subsites within the oral cavity and talk about specific cancer cases. So oral cavity cancer is pretty common. If you look at the data, it's probably the sixth most common cancer worldwide. That being said, it's still relatively rare. The incidence of oral cavity cancer has probably increased just a little bit over the last couple decades, and it's thought to have an incidence somewhere of around 12 adults per 100,000. It tends to be one of these cancers that has a stronger male predilection, with men about 3 times more likely than women to develop oral cavity cancer. The rate of oral cavity cancer is higher in white men than amongst Hispanics and black males. And it's something that we see an increased incidence with age, with a particular bump in incidence above age 65. Importantly, tobacco is a huge risk factor, whether that's smoked tobacco or chewed tobacco, as well as chronic alcohol use, chronic sun exposure, because the inner surface of the lip, the mucosal portion of the lip, is considered to be part of the oral cavity. So you can get cancer of the lip that spreads its way into the oral cavity. HPV exposure is associated with oral cavity as well, probably to a lesser extent than with oropharyngeal cancer. And then immunocompromised patients have a higher incidence of oral cavity cancer as well. It's important to keep in mind that the vast majority of oral cavity cancer is going to be squamous cell carcinoma, upwards of 90%. Now, if you're diagnosed with oral cavity cancer, your life expectancy varies quite greatly. It's dependent upon a lot of things. Chiefly important is the stage at time of diagnosis. If you have local disease only, probably somewhere on the order of around 60-65% life expectancy or survival rate. But if you have distant metastatic disease, that dwindles quite a bit. The particular subsite within the oral cavity that's involved probably has some bearing on your prognosis. Women tend to do better than men. White men and white people in general tend to do better than blacks and Native Americans. There are certain tumor-specific features, things like perineural tumor spread or vascular invasion, that portend a worse diagnosis. And then certainly, and very importantly, lifestyle modification, smoking cessation, alcohol cessation can contribute significantly to a better outcome in patients with oral cavity cancer. Probably overall, somewhere in the vicinity of 70% 5-year survival rate with oral cavity cancer. The main treatment of oral cavity cancer is going to be complete surgical resection. Sometimes adjuvant chemotherapy, adjuvant radiation therapy are offered. And particularly, we would think of that in patients that have a high risk of recurrence, older patients with medical comorbidities that might preclude doing gross total resection. Certainly, pathologic staging comes into play as well here. Margin status, so if you have positive margins at time of surgical resection, those are patients that will get adjuvant chemoradiation, or at least at a minimum adjuvant radiation. And then the extent of nodal involvement as well helps to drive that decision making. So all of that, putting it together, what is the most important predictor of your outcome? It's probably whether or not you have nodal metastatic disease. Your pathologic in category has been shown in the literature to be the most reliable predictor of patient outcomes. So how do we stage oral cavity cancer? This is based upon the AJCC staging manual. We currently use the 8th edition for oral cavity cancer. The 9th edition of this staging manual is being slowly released chapter by chapter. It started a few years ago. So far, I haven't seen dates for when the updates to oral cavity are coming out. Oropharynx just dropped this month in January of 2026. But so far, dates for oral cavity cancer have not been established. Everything that I talk about in terms of staging from this point forward is going to apply to mucosal malignancies arising in the oral cavity. As we'll see in a few minutes, some of the major salivary glands, particularly the sublingual glands, to a lesser extent the submandibular glands, do involve the oral cavity in a general sense. Those are staged differently. In fact, in 2026, this year, there will be new staging guidelines put forth by the AJCC for salivary glands. That doesn't apply to what we're talking about here. This is for mucosal malignancies of the oral cavity. Now, there is a caveat, which is if you have a minor salivary gland carcinoma, just like in other sites in the head and neck, if it originates in the oral cavity, it gets staged like a primary oral cavity malignancy. So minor salivary gland tumors do not get staged the same way as major salivary gland tumors. Okay, here's my warning slide. Just brace yourselves, get a cup of coffee, slap yourself in the face, wake yourself up. This part may be a little bit boring, but it is important stuff. I want you to at least have a sense for how we stage these. We'll talk about the important things that go into staging. That way you'll know what to include in your reports. So how do we stage oral cavity cancer? We use the AJCC 8th edition utilizing the TNM staging system, where each of these are different categories. The T category refers to the tumor, so we're talking about the size and extent of the primary tumor. N is the N category for nodes, which is whether or not there's involvement of regional metastatic adenopathy. And then M category stands for metastatic disease. We're talking about distant metastases, things like bone, lungs, brain, etc. Each of these categories will be affiliated with some sort of a numerical qualifier. It can go anywhere from 0 to 4, depending on the category. And think of that as sort of indicating the severity. If you see an X, that means that it can't be assessed or that its status is unknown. And then it comes to the important distinction of clinical staging versus pathological staging. So C means clinical, P means pathological. We'll talk more about that in a moment. All right, let's talk about the oral cavity cancer primary tumor category, the T category. This is notated to describe the existence of the primary tumor, its size, and its extent. If we see TX, that means it's unknown or it can't be assessed. Carcinoma in situ is designated TIS if you see that. And then you can get T1, T2, T3, or T4 with regards to the primary invasive tumor. And that's based upon a couple of things. Maximal tumor size, that's kind of what we used up until the 8th edition. When the 8th edition of AJCC came out, we started talking about depth of invasion. That's a pathological descriptor, not something that we can reliably assess on imaging, although there have been some papers that have looked at this. But in general, the higher the number here of your T category, the bigger the tumor and or more aggressive its local extent of spread is. So does size matters? Size matters for staging within the oral cavity, okay? We'll talk about that more in a minute. But I want to stress this point real quickly. When we talk about depth of invasion, that is a histopathological feature. It is not, I repeat, it is not the same thing as tumor thickness. Depth of invasion is something that you can tell under a microscope by looking at a plumb line that's drawn from a line that's parallel to the basement membrane of the intact membrane of the nearest intact squamous mucosa down to the deepest aspect of the tumor. So I'm borrowing this slide from Otoscape. And you can see the reference here. You can link to it if you want to learn more about this. But this is what depth of invasion is talking about. You take this line that's parallel to the basement membrane of the intact squamous mucosa. You drop a plumb line down to the maximal depth of tumor. That is your depth of invasion. That may not be the same thing as your maximal thickness of tumor, because if you have an ulcerative lesion, your thickness of tumor may vary a little bit versus whether or not you have an exophytic tumor. It may be much thicker than your true depth of invasion. All right, so let's talk about the T category with oral cavity cancer. So T1 is designated as the primary tumor that's less than or equal to 2 centimeters in thickness and has a depth of invasion less than or equal to 5 millimeters. If you have a primary tumor that's between 2 centimeters and 4 centimeters, and your depth of invasion is less than a centimeter, or less than 10 millimeters, that gives you T2. Or if you have a primary tumor whose maximal thickness is less than or equal to 2 centimeters, and your depth of invasion is between 5 and 10 millimeters, that also gets you to T2 category. T3 category is designated as tumors that are greater than 2 centimeters, but less than or equal to 4 centimeters, with a depth of invasion greater than 10 millimeters, or if you have a primary tumor that's greater than 4 centimeters in thickness, with a depth of invasion less than or equal to 10 millimeters. And then when we talk about T4 category, we're talking about the really bad actors. We're talking about moderately advanced or very advanced local disease. Moderately advanced local disease, or T4A, is when you have a tumor that's greater than 4 centimeters in maximal thickness and the depth of invasion is greater than 10 millimeters. Or if you have invasion of adjacent structures, specifically the cortical bone of the mandible or maxilla, if it invades into the maxillary sinus or invades into the skin of the overlying face. Now, one of the little caveats here is if you have superficial erosion of the bone or the tooth socket alone by a gingival primary, when we're talking about alveolar ridge squame, that doesn't get you up to T4. You really need to see full invasion. And then T4B tumor is tumor that's really, really poorly behaved. It invades out into the surrounding soft tissues in the sense that it gets into the masticator space, it invades the pterygoid plates or the skull base, or if you have internal carotid artery encasement. All right, moving on to the N category. This is notated to designate the existence, the size, and the extent of regional adenopathy, metastatic adenopathy. So if you see NX, that means it's unknown or it can't be assessed. N0 is what you want to see if you're the patient or the treating physician. Those are patients who do not have regional nodal metastatic involvement. And then you can have N1, N2, or N3 category disease. And that's all predicated on whether it's a single node involved or multiple nodes, whether it's ipsilateral or bilateral / contralateral, and then the size as well. It's important to keep in mind that when we talk about nodal metastatic disease, and this is an area that can cause confusion, there's clinical nodal categorization and pathologic nodal categorization. Very important to keep in mind, imaging. As a radiologist, the imaging staging here falls under the clinical category. Pathological always trumps clinical, but we don't always have that information. So it can get updated once pathological confirmation is available. But just know that as an imager, what data you report goes into the clinical staging. Okay, so let's talk about the clinical N category for oral cavity cancer. NX is when you have regional lymph nodes that can't be assessed. N0, best case scenario, this is when you have no regional lymph node metastases. And then N1 disease. That's when you have a single ipsilateral lymph node that is less than or equal to 3 centimeters in maximal dimension without evidence of extranodal extension. N2 disease, there's 3 flavors, N2A, N2B, N2C. N2A is whenever you have a single ipsilateral lymph node that's greater than 3 centimeters but less than or equal to 6 centimeters in maximal dimension without extranodal extension. N2B is when you have multiple ipsilateral lymph nodes that are less than or equal to 6 centimeters in maximal dimension without extranodal extension. And then the N2C category you get to whenever you have bilateral or contralateral adenopathy that are less than or equal to 6 centimeters in maximal dimension without extranodal extension. So even if you have a non-enlarged but metastatic contralateral lymph node, that bumps you up to a minimum of N2C disease. And then we get to our N3 category, in which we have N3A, which is a metastasis in any lymph node that's greater than 6 centimeters without extranodal extension. And then there's N3B disease, which is a metastasis in any lymph node that has clinically overt extranodal extension. So for clinical N category, if you have clinically overt extranodal extension, that bumps you up to N3B category disease. Now the question then is, what constitutes clinical extranodal extension? That's whenever you've got jailbreak of tumor leaving the lymph nodes and invading the skin, if it infiltrates and fixates to the adjacent muscles, or if it involves cranial nerves, brachial plexus, sympathetic trunk, or phrenic nerve with dysfunction of the affiliated nerves. All right, let's talk about then what we mean by the pathologic nodal category. So NX, again, easy to wrap your head around. That's just when the lymph nodes can't be assessed. N0, again, best case scenario, no regional adenopathy. N1 is the same as the clinical. If we have a single ipsilateral lymph node that is 3 centimeters or less in maximal dimension without extranodal extension. And then N2A is where we get our first break in where the pathologic nodal staging doesn't quite align with the clinical. Again, once you get the true pathological staging, that sort of supersedes your clinical staging. So N2A nodal category, pathologic nodal category, is when you have a single ipsilateral lymph node that is greater than 3 centimeters but less than or equal to 6 centimeters in maximal dimension without extranodal extension, or if you have metastasis to a single ipsilateral lymph node that is less than or equal to 3 centimeters in maximal dimension with extranodal extension. This is sort of the oddball caveat. We will allow up to one ipsilateral small, i.e. less than 3 centimeter lymph node with extranodal extension. If you have just one, on a pathological assessment, pathologic basis, that can put you back to N2A. Pathologic N2B nodal category, that's when you've got multiple ipsilateral lymph nodes that are less than or equal to 6 centimeters in maximal dimension without extranodal extension. N2C pathologic nodal categorization is if you have bilateral or contralateral nodal disease less than or equal to 6 centimeters without extranodal extension. And then our pathologic N3, our N3A is the same as the clinical, Mets in any lymph node greater than 6 centimeters without extranodal extension. And N3B is essentially the same as the clinical. It's whenever you have metastatic disease involving any lymph node with extranodal extension, with that one caveat that we talked about before. If you have a single ipsilateral lymph node less than 3 centimeters in size with pathological confirmation of extranodal extension, that specific subtype, that specific caveat puts you at N2A disease. Okay, so what is considered pathological extranodal extension? That's simply extension of metastatic tumor beyond the confines of the lymph node as seen under a microscope. And then moving on to the distant metastases category, this one's super simple. It's whether or not you've got distant metastases. It's binary. M0 is if you have no evidence of distant mets, M1 is if you have distant mets. With oral cavity cancer, we're thinking about the usual players, the lungs, the bone, the liver, the adrenal glands, the brain, etc. Most commonly, lung. Okay, so then we take all of that information, and I don't report this in my reports. I just put the information out there so that collectively, as a tumor board, the staging can be appropriately assigned. But oral cavity cancer staging under the AJCC 8th edition paradigm uses the same nodal and group staging, this shared group staging that you'll see at other sites in the head and neck. Again, it relies on this TNM categorization to arrive at the final disease stage. Some key features, things that I think are important to kind of wrap your head around because they're honestly pretty easy to remember, is if you have T1 N0 disease, that puts you at stage 1. So T1 N0 stage 1. If you have T2 N0 disease, that's stage 2. And then anytime you have distant metastatic disease, any M category, any M1, that puts you to stage 4C automatically at the highest level. So if you can remember those three things, it just sort of progresses in a stepwise fashion as you work your way out this sort of Punnett square type table. Okay, so that is an absolute lot to throw at you. And I apologize for that, but it is important that we walk through it. You understand the things that go into staging so that you can report what people need to know to appropriately stage it. I try to simplify this. I don't report an actual stage in my reports, but I give all the information that you need to stage. I talk about the primary tumor. Obviously, I find it, talk about where it's at, talk about its size, and then I talk about what it invades. If it has deep invasion into the surrounding structures, that upgrades disease to T4 tumor. Talk about metastatic lymph nodes. The laterality. Are they ipsilateral? Are they bilateral/contralateral? What's the size of the biggest lymph node? if you look at the AJCC criteria, it's not largest short axis, largest long axis diameter. It is the biggest diameter, whether that's coronal, sagittal, axial, some oblique version of any of those. Biggest diameter is what goes into the staging. And then I look for imaging findings of extranodal extension. Does it have shaggy margins? Do we see little tendrils of tumor extending out of the lymph node, invading into the overlying muscle, encasing the vessels, that sort of thing? We're not perfect when it comes to extranodal extension, and I'm sure you'll be learning more about extranodal extension of disease that applies to HPV-positive oropharyngeal squamous cell carcinoma, because that is now part of the AJCC 9th edition for staging oropharyngeal squamous cell carcinoma. I don't truly know what's going to happen with oral cavity, whether extranodal extension is going to be a disease modifier whenever the new staging comes out for this. I suspect it's certainly possible. But I do at least report things that look suspicious for extranodal extension, knowing full well that we are not great at imaging at predicting it. Our reliability is actually pretty poor. Obviously, you want to look for distant metastases because that's going to bump you all the way up to stage 4 disease. I report what the surgeons, the oncologists, the rad oncs, what do they want to know so that we can appropriately stage these patients. But I don't report an actual stage. I think that's a decision that's best left to a collective tumor board to come up with. Now, if you want to try to remember numbers, I think the things to remember are 2 and 4 and 3 and 6, right? So as we talk about your primary tumor, your T category, is it less than 2? Is it between 2 and 4? Is it greater than 4 centimeters? When we talk about lymph nodes, are they less than 3? Are they greater than 3, but less than 6, or greater than 6 centimeters? Now, we can have a philosophical discussion about whether lymph nodes can truly get up to 6 centimeters in size. I kind of highly doubt that they can. I think when we're talking about something like that, we're talking about conglomerate nodal disease rather than a true single 6 or 7 centimeter lymph node. But that's not how the AJCC has declared this. I think as we're talking more about conglomerate lymph nodes in the future, that may really sort of play a role in determining whether or not this is actually extranodal extension of disease. So my advice, stay tuned to what the AJCC puts out moving forward about this. But for now, for the primary tumor for your T category, less than 2, 2 to 4, or greater than 4 centimeters. For your N category, less than 3, 3 to 6, or greater than 6 centimeters. All right, we're done with that painful section. Now let's talk about some stuff that's a bit more exciting. We're going to first talk about imaging anatomy, because in order to diagnose and stage oral cavity cancer, you really have to have a good understanding of the anatomy. That's going to help you to localize and stage the tumor. So when we talk about the oral cavity, we've got some important considerations. First of all, it's all covered with oral mucosa. So there's this mucosal surface that drapes over all of these structures within the oral cavity, and that's where the cancer actually originates from. We've got the root of tongue, which are these deep extrinsic tongue musculature. They're part of the oral cavity, but they're not part of the extrinsic musculature of the tongue. The sublingual space, and then the submandibular space. All of that in total sort of makes our oral cavity. And we'll talk more about each of these and what they look like on imaging moving forward. So let's talk about the oral mucosal surface. So as we think about the borders of this mucosa that's draped over all these structures, we've got it extending up from the hard palate above, the buccal mucosa out laterally, the gingival mucosa along the alveolar ridges, the lingual mucosa along the tongue. But in general, this yellow arrow kind of traces out the general borders of the oral mucosal surface. We can see it extends along the inner surface of the lip as well. And it contains mucosa and minor salivary glands, but not the tonsils. Your palatine tonsils and your lingual tonsils are part of your oropharynx. They are a totally different beast, a totally different site of head and neck cancer. That does not apply to anything I'm talking about here. The tonsils, the oropharynx, that sits posterior to the oral cavity. Now, there's no investing fascia, which has ramifications in terms of how these tumors can sort of blow up and spread. And the importance of all of this is it is all covered in mucosa. That's where squamous cell carcinoma comes from. So squamous cell carcinoma is our chief problem, our chief malignancy here. So let's talk a little bit about the oral cavity proper. It's bound by these alveolar arches of the maxilla and mandible, these tooth-bearing arches of your jaw. The oral cavity proper is defined here in sort of this purplish blue color. We can see the base of tongue, the lingual tonsils, the oropharynx, that all sits back behind it. Now, it communicates. It's directly contiguous in terms of mucosal covering with the oropharynx. So you can have cancer that starts in the tongue and spreads back into the oropharynx and vice versa. The roof of the oral cavity is going to be the hard palate and the maxillary alveolar ridge. The floor is going to be made up of a floor of mouth mucosa. We'll talk more about that in a minute. And we can think of the oral cavity proper as containing the anterior 2/3 of the tongue. There's no tonsillar tissue. This is all ventral to the circumvallate papilla. Anything that sits in front of that lacks tonsillar tissue. Now, as we look in the oral cavity, we've got this space, this potential space, if you will, called the oral vestibule, and it's going to be lined out laterally by the buccal mucosa, and it's going to have the reflection of the gingivobuccal mucosa along these alveolar ridges. And so this yellow area in this puffed cheek CT is going to be our oral vestibule. And we've got these gingivobuccal sulci, we've got a superior one, we've got an inferior one, and that's sort of the reflection along the alveolus of the mandible out toward the buccal mucosa. And so that's an important area where cancer can originate, and because of the very, very close proximity to bone, those patients are more likely to have higher T category tumor at presentation because it erodes right into the bone. Let's talk about the retromolar trigone for just a moment. This is a really small but critically important oral cavity subsite. You can kind of think of this as the crossroads of the oral cavity, the oropharynx, the soft palate, buccal space, floor of mouth, masticator space, parapharyngeal space. In the head and neck, we love these crossroads like the pterygopalatine fossa, the retromolar trigone, because pathology, when it gets there, it can start spreading in different directions. And so we result in these, it results in these sort of complex, these spread patterns of tumor that you need to know about. So what is the retromolar trigone? It's this small triangular region of mucosa that's found posterior or behind the last molars of the mandible. And it's going to extend superiorly up toward the maxillary tuberosity near the third molar. So here we can see on this axial T1 weighted image, this is our posterior-most molar. We can see this mucosa that sits right back behind it near the ramus of the mandible. This is our retromolar trigone. Now, sitting just deep to the retromolar trigone is going to be our pterygomandibular raphe. This is a fibrous band of connective tissue that forms at the junction of the buccinator and the superior constrictor muscle. It's kind of where it zips up like a zipper. And it extends from the mylohyoid ridge of the mandible all the way up superiorly or cephalad toward the medial pterygoid plate. So as you can imagine, if you have a retromolar trigone tumor, squamous cell carcinoma that invades that, it can sort of act as a highway by which tumor can track up toward the skull base. Now, tumors are aggressive, are they super well behaved and they just, sort of funnel their way up this pterygomandibular raphe? No, not exactly. But think about this concept of it is sort of a pathway of spread. When a tumor gets big enough and aggressive enough, it sort of blows up in all directions. But this is a potential conduit of spread, funneling the tumor up toward the skull base. Now it's found deep to the retromolar trigone. So again, right here was our retromolar trigone, that mucosa posterior to the posterior molar. This pterygomandibular raphe is the junction of where the buccinator muscle ties into the superior pharyngeal constrictor muscle. It's where they zip up. And so if you have a tumor that invades that, you can see how it potentially could get funneled. Now, you can also have tumor that blows its way laterally into the masticator space. It can blow its way medial into the masticator space. It can get into the oral tongue. It can extend back to the oropharynx. So this is a really important way station within the posterior oral cavity. All right, next is the root of tongue. And we can think of these as the sort of the deep midline tongue structures, denoted here in yellow. It's on this coronal T1 weighted image. And the contents are the genioglossus and geniohyoid complex. So here's our genioglossus muscle right here. Here's our geniohyoid muscle, so that complex of muscle with this lingual septum sitting between it. That's going to make up our root of tongue. Sitting down below or inferior to the root of tongue, note the relationship with the mylohyoid muscle. So here's our root of tongue, our genioglossus, our geniohyoid. Sitting right up against that mylohyoid, I've heard this described as the levator ani of the floor of mouth, this mylohyoid sling. And then out anteriorly on this axial T1 weighted image, we can see that the root of tongue extends right up to the mandibular symphysis at this little bumpus, the genial tubercle. Next is the sublingual space. Now, this is found submucosally. It's not part of the mucosal oral cavity, but it's all, because this all lacks this, neatly defined fascial boundaries, we kind of lump this together with the oral cavity. And it's important because of the deep spread of floor of mouth squamous cell carcinoma can get down into the sublingual space, and we'll talk more about that later in the talk. But the sublingual space is going to be found deep or medial to the mylohyoid muscle, and it's going to be an oral cavity only structure. So here, defined in yellow, is where the sublingual space is seen on the axial T1 image. So here's our mylohyoid muscle. And our sublingual space is going to live just medial or deep to that. Now, what does the sublingual space contain? It's going to have quite a few important things, including the sublingual gland and duct. Part of the submandibular gland pokes up into it, so we can see this little uncinate of the submandibular gland. Here's our submandibular gland. The uncinate pokes in like the finger, like the thumb on a mitten, wraps around the mylohyoid muscle and pokes into the sublingual space. We're going to have our submandibular duct that runs through the sublingual space in the floor of mouth. We've got cranial nerves 9 and 12, as well as the lingual nerve, chorda tympani, and the lingual artery and vein, all live within the sublingual space. Now, what's the importance here? Again, floor of mouth squamous cell carcinoma overlies it and can invade down into it. We can also get salivary gland malignancies. Obviously, we've got the sublingual gland. That can be the site of major salivary gland malignancy, but we have minor salivary glands that live here too, and those can truly mimic squamous cell carcinoma on imaging. In fact, a lot of these sublingual spaces, floor of mouth, squamous cell carcinoma, are really, we can't decipher exactly what the primary tumor is on imaging. So here's the sublingual space shown diagrammatically on the left and on this coronal T1 weighted image on the right. We can see denoted here in yellow. Again, it's going to live lateral to the root of tongue. So here's our root of tongue. It's going to be above or deep to our mylohyoid muscle. And we can see it right here. And it's denoted here in green on this diagram, sort of encasing the hyoglossus muscle, but sitting above or central to the mylohyoid muscle. Now, the submandibular space is an important space that's related to or tied in with the oral cavity. And this is found deep to the platysma, but superficial to the mylohyoid. We can see it on imaging here on this axial T1 weighted image, denoted here in yellow. And it's going to contain the submandibular glands themselves, at least most of it. There's a little bit that pokes its head into the sublingual space, but the submandibular glands, the majority of them live in the submandibular space. Important to head and neck cancer of the oral cavity. This is where we find our level 1 lymph nodes. That's the top location for occult nodal metastatic disease with oral cavity cancer. The most likely place you're going to see it. We also have the facial artery and vein, the anterior belly of digastric, and cranial nerve 12 living within the submandibular space. Why is the submandibular space so important to oral cavity cancer? As I said, metastatic adenopathy, level 1 nodal metastatic disease. This is where you really need to be scrutinizing the most. And then you can have salivary gland tumors that originate here, both primary of the submandibular gland itself as well as the minor salivary glands. But in this talk, we're focusing on predominantly squamous cell carcinoma. Here's the submandibular space shown diagrammatically on the left and on the right on this coronal T1 weighted image. This horseshoe-shaped structure, it's superficial to the mylohyoid, it's deep to the platysma, it's one big connecting space that's got submandibular gland, it's got level 1 lymph nodes in it. Let's talk ever so briefly about these submandibular space lymph nodes because they're important for staging of oral cavity cancer. We've got our level 1A lymph nodes that are found between the medial margin of the anterior bellies of digastric, and we've got our level 1B lymph nodes, or our submandibular nodes, that are going to be found posterior and lateral to the medial margin of the anterior belly of digastric, and they're situated either around or in front of the posterior margin of the submandibular glands. So level 1 lymph nodes, really you need to be looking very carefully. Obviously, you need to look at all the lymph node stations, but with oral cavity cancer in particular, that's the most likely first step in nodal metastatic disease. So level 1A lymph nodes, level 1B lymph nodes, normal reniform morphology, maintained fatty hilum. These are situated, the level 1As situated between the anterior bellies of digastric. Level 1Bs are situated lateral to the anterior belly of digastric, but ventral to the back end of the submandibular gland. These are normal lymph nodes. Now, we can see reactive adenopathy at these nodal stations. This is benign, sort of reversible enlargement of lymph nodes due to some sort of antigenic response or antigenic stimulus. They become enlarged, but still tend to maintain a generally reniform morphology. They oftentimes are a little bit hyper-enhancing, but if you look carefully, you'll see this linear hilar vascular enhancement. That's a very good indicator that you're dealing with a reactive lymph node. These are non-necrotic. Now, metastatic adenopathy. The submandibular space lymph nodes are commonly seen in the setting of metastatic squamous cell carcinoma from oral cavity cancers. Here's a diagram of a lateral tongue oral cavity cancer with metastatic adenopathy at a 1B nodal station. Whenever we encounter metastatic adenopathy, most commonly, if it's at the level 1 nodal station, most commonly we're thinking about oral cavity cancer, but you certainly can get it from oropharyngeal cancer as well, sometimes even cutaneous malignancies. People talk about size criteria for adenopathy. I think it's a really antiquated and quite worthless proposition because cancer nodes get big, but guess what? So do reactive lymph nodes. I think it's way more important to look at the morphology and the enhancement pattern of the lymph nodes. Are they becoming rounded? Are they losing their fatty hyla? Are they heterogeneously enhancing with areas of necrosis? Are they becoming more cystic? Those are much more important features, and those are the things that I'm really keying in on. Here we can see this mildly hyper-enhancing but very rounded lymph node in this patient with a lateral tongue cancer. All right, let's talk about some imaging techniques for assessing oral cavity cancer. So most of these lesions are going to be encountered primarily on physical or dental exam, and we do imaging to further assess. So the roles of imaging, importantly, we want to try to map the extent of the primary tumor. We want to look for osseous involvement with erosion of bone or marrow replacement. We want to search for metastatic adenopathy and distant metastatic disease. And as a radiologist, you really want to be looking for things and reporting things that upstage disease. So it's important to kind of know a little bit about that staging that we talked about previously. Now, contrast-enhanced CT is typically our first-line imaging modality for oral cavity cancer, but it has its limitations. And I will be honest, it's probably not the best modality, but it's widely available, easy to get patients in, relatively inexpensive compared to MRI. So we probably do more contrast-enhanced CT for this, but MRI is honestly probably the better tool. Now, why is CT limited? Well, a couple things. Most of the time, we're running into patients that have streak artifact from dental amalgam. Most patients tend to have some degree of dental work. That can cause a lot of streak artifact, and that can obscure the oral mucosa and completely blind us to these tumors. The other thing is sometimes these tumors are quite subtle, and if you have mucosal apposition, for example, the buccal mucosa plopped right up against the mucosal lung, that gingival-buccal sulcus, that may completely obscure the primary tumor. So it's really critically important that you get a good clinical history, you read the notes, you see where they're seeing the tumor, and you really scrutinize those areas. Now, there are some tools that we can use to mitigate some of those artifacts, and we'll talk about that here in a moment. So in general, give contrast. Unless you have a contraindication for giving a patient contrast, all these patients should get contrast. And you want to make sure there's an appropriate delay. We don't want an early arterial phase of study. We want time for that tumor to perfuse and to soak up that iodine and differentiate itself from the rest of the oral mucosa. It's really critical that you do multiplanar reformats, that you're looking in multiple planes, and that you look at the bone algorithm reconstructed images to look for osseous erosion. I think there's an emerging role of using some of these newer CT tools like photon counting CT or dual energy CT or spectral detector CT imaging to really help with increasing the conspicuity of these enhancing lesions, but also to help mitigate some of this beam hardening artifact and streak artifact that we get. And we'll talk more about that. So how do we combat some of this oral cavity streak artifact? So one of the things that you can do is to have an angled gantry axial acquisition. And if you can't angle your gantry, you can tilt the patient's head back or tilt their chin forward. And so that requires a separate acquisition from the straight axials that you might be doing. And the whole point in doing that is the streak artifact gets shifted in the plane of the angle of the gantry. Now, the downside of this is it is a second pass, so it is going to be increased ionizing radiation exposure to your patient. But we oftentimes get images that look like this. all this spray artifact coming off the dental amalgam, impossible to know if they have a tumor along the left lateral tongue here. So here's an example of how you can combat that streak artifact, that spray artifact from dental amalgam. So this was the patient's axial contrast enhanced CT image. Here's the localizer. We can see that straight axial acquisition. Lots of artifact obscuring the left hemitongue. This is the plane of acquisition for an angled gantry or angled axial CT acquisition. It's going to throw the streak artifact into that plane, and it's going to shift it off of the tongue. So same patient, this image was acquired maybe 30 seconds later, we can see that left lateral oral tongue is no longer getting streaked out. So that can really help, and it shifts that streak artifact into the plane of the gantry. There's all sorts of different metal artifact reduction techniques that the different vendors do. These are algorithms that detect metal and detect photon starvation, and they can sort of replace or interpolate data. It can be done as projection-based, in which it's manipulating the raw data, or versus image-based correction. Each of the vendors has their own flavors, and I think it can be quite helpful. Sometimes it's a little too helpful, and it just sort of blurs everything out, but in general, I think it does a decent enough job of reducing some of the streak artifact. So this is a patient on the axial CT image. We can see beam hardening artifact, streak artifact, really effacing or obscuring the left hemitongue. This is using the IMAR sequence, and you can see that it cleaned up a lot of that artifact, and there's maybe a little bit of subtle mucosal hyperenhancement there. Now, would I call this prospectively? Maybe not, but this is why you read the notes and you look at the clinical notes, and they say, no, the patient has a left lateral oral tongue mass. That's what it is right there. Totally obscured on the routine, but using the IMAR sequence or IMAR technique, we can clean up some of that streak. And this is just to confirm this was the patient had a PET CT. Sure enough, that's exactly where the primary cancer was at. So I think the metal artifact reduction techniques can sometimes be helpful, but they're most helpful if you actually know where to be looking at. So always read the clinical notes. Now, if you're doing things like photon counting CT or spectral detector imaging, you can reconstruct the images using only high energy photons. And those high energy photons are more likely to get through all of that beam hardening from the dental amalgam. Now, the trade-off is if we create images at higher mono E values, we're getting further away from the K edge of iodine. So the avidity of contrast enhancement is going to decrease, but we're going to be able to penetrate better through that. So that's the trade-off. There's always trade-offs. So this is a patient that we did on our photon counting CT. This is a mono E40 reconstructed image. Lots of spray artifact. I don't know, is there something hyper-enhancing the left hemi-tongue? Good question. So again, this is the area we want to interrogate. Let's look what this looks like if we generate an image at 70 kiloelectron volts. We get less of that artifact. Doesn't go away altogether, but we have less of it. And I really don't see anything that looks quite so suspicious here. We can still see contrast enhancement, but it's not as avid because we're further away from the K edge of iodine. Now you can take that higher mono E image and you can run it through the metal artifact reduction and clean it up even further. And now I can feel quite a bit more confident that there's really nothing going on there. And so I think that you can kind of play around with these high and low energy values to troubleshoot some of the streak artifact, and you can use it in conjunction with the metal artifact reduction techniques as well. So we talked about streak artifact. What about the challenges we get when we get mucosa against mucosa? Well, one of the classic techniques to combat this is to do a puff cheek acquisition. And you have the patients insufflate their cheeks. They blow them up like they're a jazz trumpeter. And that air separates the buccal mucosa from the gingiva buccal sulci and the teeth. It pulls it away so that we can actually see the mucosa much better. So here we can see this large invasive mass along the gingiva buccal sulcus, the buccal mucosa, alveolar ridge, big squamous cell carcinoma. So you might think, oh, that's great. Why don't we do this routinely in everybody who gets in the scanner? Well, the problem is if you have someone doing a puff cheek technique, they tend to want a Valsalva that can cause glottic closure, so we get obscuration of the true vocal cords. It also, with those pressures, can shift the nasopharynx and efface the soft palate, and so there are trade-offs to doing it. So I think it's best to be done judiciously. anytime you get an indication oral cavity cancer, it's probably worth doing a dedicated pass with a puffed cheek technique. So here's just an example of how useful it can be. I'll tell you this patient has an oral cavity cancer. If you're looking very closely, you can see it on this image, sure enough, but I think it's a lot easier to see on the second image with the puffed cheek technique. And so this is an alveolar ridge squamous cell carcinoma. It sort of gets blended amongst the mucosal apposition here, but when we separate that using the puffed cheek technique, it really stands out. Okay, so we talked a lot about CT. Let's talk about the other modalities. And an MRI, I think, is an incredibly valuable imaging tool for oral cavity cancer. It is far less susceptible to artifact from dental amalgam, although you certainly do get susceptibility artifact. So I think that a lot of the issues that we see on CT get cleaned up on MRI. We just don't get the same kind of really heinous artifact. So it's much better to sort of delineate and map the margins of the primary tumor to evaluate for tumoral invasion of the surrounding soft tissues. I really think MRI is probably the preferred modality, but for practical reasons, it's less commonly employed than CT. PET is fantastic. Oral cavity squamous cell carcinoma is reliably FDG avid. And so it really is a good tool. You can do it with CT, or you can do PET MRI, and you get that sort of additional added benefit of probably improved nodal evaluation as well. But obviously higher radiation exposure, and more expense and that sort of thing. Ultrasound, boy, here in the U.S., probably not really a main player, although there is maybe a growing role of intraoperative ultrasound for tumor mapping and helping to predict depth of invasion up front. So I'm not going to talk really any more about it. It's not a tool that I really have in my toolbox, but there are places that use it. Here's a case just to talk about the value of multimodality imaging. This patient has oral cavity cancer. So the question is where? It can be really, really subtle on CT. You get, the teeth, the beam hardening artifact of dental amalgam, the apposition of mucosal surfaces. If I've had 3 or 4 cups of coffee first thing in the morning, especially if I'm looking at the clinic note, sure, I think I'll find this, but it's pretty subtle. What about if we look at our T1 weighted image? It's there. You just kind of have to know what you're looking for, and you want to look for effacement of the tissue planes and infiltration of the tissue planes. What about our T2 weighted image? Yeah, I'm not missing it on this. So we've got a left lateral tongue squamous cell carcinoma, the oral cavity. It's sort of low T1, high T2 signal. And if you look in retrospect, yeah, we can see it on the CT. It's hyper enhancing, just a little bit more dense than the intrinsic tongue musculature. Give contrast, we can see very avidly enhancing on MRI as well. And then here's our FDG PET showing that it's FDG avid. Here we can see on our coronal T1 weighted image, coronal T1 post contrast, this infiltrating, enhancing left lateral tongue mass. Here's where I think that the T1 pre-contrast image is useful. We can see that this tumor is invading into the hyoglossus muscle right here. So here's the normal hyoglossus muscle on the contralateral side. We can see it's invading into it. That's no longer something that upstages tumor like it used to be in older editions of the AJCC, but it is still worth reporting for surgical considerations. So, I think PET MRI, PET CT, MRI, they're all going to be more sensitive than contrast-enhanced CT. MRI is really nice for mapping out the sort of the local invasion of the tumor. All right, so the last part of this talk, we're going to burn through some cases of all of the different oral cavity head and neck cancer subsites. And so really these are the usual suspects. If you've seen this classic movie, here's the usual suspects of oral cavity cancer. And we're going to start off by talking about oral tongue squamous cell carcinoma. So oral tongue squamous cell carcinoma is going to be squamous cell carcinoma that arises along the anterior 2/3 of the tongue, most commonly involving the lateral tongue, but certainly can extend down to the undersurface and at the tip of tongue. And if you think about it going down to the undersurface, you can imagine how this is all just sort of this carpet of mucosa that drapes everything, and it could certainly spread down to the floor of mouth. Clinically, these patients tend to present with painful, non-healing ulcers, much more common in men than in women, about a 4-to-1 ratio. As I mentioned before, strongly associated with tobacco and alcohol use as well. And as I mentioned before, nodal drainage. Oral cavity cancer, we are looking really, really closely at our level 1 and level 2 lymph nodes. Start with the level 1s, most commonly seen at level 1B. Next stop, level 2A. But here's the deal. You can actually get skip lesions. You can have oral cavity cancer that presents with lower neck metastatic adenopathy, sparing level 1, sparing level 2, sparing level 3. Sometimes it happens. So you really truly have to look at all of the lymph node stations within the neck. Just know that statistically it's most likely going to start off at level 1B and then spread stepwise down to 2A. Just know those skip lesions can occur. Here we've seen this diagram before. Lateral oral tongue squamous cell carcinoma, metastatic adenopathy, level 1B nodal station. Treatment's going to be surgery plus or minus XRT. All right, so oral tongue squamous cell carcinoma. This can be difficult to see on imaging. I've shown us some examples of how it really can be challenging to see on CT. And those were, pretty big tumors. When they're small, when they're superficial, boy, they can be imaging occult, okay? Even though you know where to look, sometimes you just don't see them. So that's a real challenge to imaging. On CT, these can be variably enhancing. Sometimes they're exophytic. Many times they're endophytic and ulcerative. And so that can be a challenge. But you want to look very carefully for bone erosion because that's going to upstage this to T4 tumor. Here we can see this large lateral oral tongue invasive hyperenhancing mass, this metastatic adenopathy, hyperenhancing round level 1B lymph node. On MRI, I showed a case of it before, but we'll show some more here moving forward. T1, hypointense to the tongue, usually T2 hyperintense, may have reduced diffusivity. These tend to be fairly cellular tumors, so I really like diffusion imaging. If you've ever worked with me or heard me talk before, I'm a huge fan of diffusion imaging. These tend to enhance heterogeneously and reliably FDG avid. So complementary imaging modalities. So here's a patient with oral tongue squamous cell carcinoma. Here's our axial T1 weighted sequence. This is our pre-contrast T1. Subtle, but you can see this low T1 signal lesion along the lateral oral tongue. We're not missing on the T2. This one's very T2 bright. It's invasive. Enhances pretty avidly when we give contrast. And it's FDG avid. So this is kind of a characteristic look of a lateral oral tongue squamous cell carcinoma. Moving next to the floor of mouth squamous cell carcinoma. So as the name would imply, this is squamous cell carcinoma arising from the mucosa of the floor of mouth. This is going to be the mucosa that overlies the mylohyoid and hyoglossus muscles. We saw that relationship previously. And it's going to wrap its way up. It's going to be contiguous to the undersurface of the tongue. So if you have a tumor that starts in the floor of mouth, it certainly can grow into the oral tongue and vice versa. This is highly associated with tobacco and alcohol use. And don't forget about chewing tobacco. You're putting chewing tobacco potentially into this location. This is, that's a big risk factor. One of the important things to keep in mind, and we talked about the close anatomic relationship with the sublingual space, is a floor of mouth squamous cell carcinoma can present with obstruction of the ipsilateral sublingual or submandibular glands. They may present with obstructive sialadenitis because it invades and it obstructs the ducts. The other really important consideration, this diagram shows it really nicely, is proximity to the mandible. Look for mandible invasion. That's going to upstage you to T4 tumor. And then again, those occult mets, quite common with floor of mouth squamous cell carcinoma, most commonly presenting level 1B nodal disease. This is a really challenging place to find cancers on imaging, especially on CT. They tend to be pretty ISO to the rest of the structures here. They don't usually just jump out at you and scream in your face, hey, I'm a tumor, come find me. Instead, you kind of see this tissue distortion. So we see sort of these tissue planes on the normal contralateral side, these bands of alternating hyperdense and hypodensity where the muscle and fat and fascia are at. We are losing that in the left anterior floor of mouth. On CT, these are variably enhancing. CT is great for looking at bones. We want to look for that mandibular erosion. We want to look for those potential features of obstructive sialadenitis that I mentioned. On MRI, they tend to be T1 hypo, usually a bit T2 bright. I love the diffusion imaging. Again, these may have restricted diffusion due to their cellularity, heterogeneously enhancing, reliably FDG avid tumors. So here's a patient. This is actually the same patient, just a slice a little bit more inferior, with a floor mouth squamous cell carcinoma. Challenging, but look at that tissue distortion, that fullness, that heterogeneous attenuation, something fishy going on here. Look at the bone. It's starting to get a little bit permeative sclerotic. Maybe the cortex is looking a little shaggy. That's worrisome that we've got something involving the marrow space of that mandible. On coronal CT, again, sort of this heterogeneous this tissue distortion, the heterogeneous attenuation. Could I tell you up front this is a squamous cell carcinoma? No, this could be a sublingual gland primary malignancy. I can't tell you on imaging. It's just such a crowded space. We don't delineate it well. That's something that has to have histopathological confirmation. On the T1 weighted series, again, hypointense. That's a common feature with these. Look how we're distorting these tissue planes. We're losing that normal sublingual space tissue plane here with that invasive tumor. Look at the mandible. That marrow is getting replaced. Give contrast. Infiltrative, indistinct, irregular, invasive, ugly margins. Very scary look to that tumor. Seeing some abnormal enhancement within the marrow space as well. Here's the coronal. Nice for mapping out the involvement of the root of tongue as well. FDG, again, reliably FDG-avid tumors. All right, moving on to the alveolar ridge squamous cell carcinoma. This is squam that arises from the gingival mucosa along the alveolar ridges, either of the mandible, as this diagram shows, or the maxilla. Because this is essentially paper-thin mucosa overlying the bone, these have a predilection for bone invasion at time of presentation just due to that proximity. These are oftentimes T4 tumors at time of presentation. One of the things you want to think about with alveolar ridge squamous cell carcinoma is perineural tumor spread. And that's because if it's involving the mandible, it can invade down into the inferior alveolar nerve canal and get on that branch of cranial nerve V3. Or if it's involving the maxilla, it can invade up to the palatine canal and work its way up to the pterygopalatine fossa. So think about perineural tumor spread with alveolar ridge squamous cell carcinoma. Now, because this is all mucosal carpeting, draping all of these structures, you can get contiguous spread. If it's arising from the mandible, you can contiguous spread out to the buccal space, out to the masticator space, down to the floor of mouth. If it's arising along the maxilla, it can invade up into the palate or into the sinonasal cavity. So the lack of robust fascial planes separating all of these makes for very complex and unfortunately aggressive spread patterns. Oftentimes, this is very subtle and easily obscured due to that mucosal apposition or beam hardening artifact. This case may be not so subtle. Big mass, alveolar ridge, sort of growing its way up along the buccal mucosa as well. Very common that it grows its way up. And you can see where the red arrows are sort of showing how this mandible is getting sort of excavated out by this aggressive tumor. So CT, it sounds like a broken record, heterogeneously enhancing, may or may not have bone destruction, oftentimes do just because of its proximity. Look on the bone recons to see if that inferior alveolar canal, if you're dealing with a mandible or if you're dealing with a maxillary primary, if the palatine canal is becoming enlarged, because that may be a marker of occult perineural tumor spread. On MRI, these tend to be fairly moderately enhancing. Look for that marrow replacement. Look for that perineural tumor spread. Again, FDG-avid tumors. PET is a very important tool for staging these. This is a patient that's got a right mandibular alveolar ridge squamous cell carcinoma. We can see this ulcerative mass sort of eroding out the mandible, causing some really substantial bone destruction. We do a contrast-enhanced T1 axial sequence. We can see it's heterogeneously enhancing with the soft tissue. But look very carefully. That inferior alveolar nerve is just a little bit thickened compared to the other side and maybe ever so slightly more hyper-enhancing. If this were the only feature of this, I would be kind of questioning whether or not there's perineural tumor spread. Just because we do oftentimes see, in fact, we expect to see some enhancement along it, but this is a little bit thicker, so I'm worried. But take a look as we move our way into the infrazygomatic masticator space where that inferior alveolar nerve, where it's now becoming sort of cranial nerve V3 proper, very thick and very enhancing. This is perineural tumor spread on cranial nerve V3. Coronal T1 post-contrast, we can see that cord-like thickening working its way up toward the foraminal valley. And, we don't always see this, but here's just a nice example of sometimes we do. FDG avid perineural tumor spread all the way up at the foramen valley. So alveolar ridge squamous cell carcinoma, be on the lookout for perineural tumor spread. If it's along the mandible, we're looking along cranial nerve V3. If it's along the maxillary alveolus, think more about greater palatine nerve canal getting infiltrated. Take a very close look at your pterygopalatine fossa. All right, moving next to buccal mucosal squamous cell carcinoma. This is a squame that arises along the inner lining of the cheeks, but also don't forget the lip, that transition point of your lip where the vermilion red becomes your mucosa. You can have buccal mucosal squame developing along the mucosal margins as well. This is something that I think is quite easy to overlook on routine imaging. And so it's a nice area to be doing that puff cheek CT. You could do a similar thing on MRI. We don't want patients to be puffing their cheeks for 2 or 3 minutes per sequence, but instead you can pack it with gauze, because that's going to be typically going to be sort of iso intense or sort of hypo intense on MRI. So we can sort of pack it with gauze to push the mucosa out of the way as well. You want to look for that contiguous spread along the floor of mouth, the alveolar ridge, because this is like a carpet. It just likes to creep along the carpet of the mucosa. Buccal mucosal squamous cell carcinoma has a propensity for metastatic disease to the regional lymph nodes. You want to look at level 1 and 2, and then also those non-numbered buccal and facial nodes can be involved as well. This is highly associated with tobacco use, where they put the chewing tobacco in their cheek, but also betel nut pon use around the world can predispose for buccal mucosal squamous cell carcinoma as well. This can be very subtle, maybe not this case that I'm showing here, but it can be quite easily obscured. What we're looking for is sort of that asymmetric thickening of the buccal mucosa. I like looking at the overlying buccal fat. If it's looking angry and infiltrated, that is really a tip-off that something bad is happening. The enhancement can be a bit variable on CT. On MRI, it tends to be T1 iso, T2 hyper intense, variably enhancing. Again, look at that infiltration of the buccal mucosa. I'll show of the buccal fat. I'll show an example of that here momentarily. And these are reliably FDG avid tumors. Here, hopefully I'm not walking past this, markedly thickened, infiltrating. We see these tendrils of tumor extending out. This one's actually getting through the buccal muscle as well. So this is a very aggressive case that hopefully we're not walking past. So this is maybe a little bit more subtle on the T1 pre-contrast, maybe looking just a little bit thickened in that mucosa. And on the T2, it's maybe ever so slightly T2 hyperintense, but really what stands out to me on this is that infiltration of that overlying buccal fat. We give contrast. Okay, this is pretty heterogeneously hyper-enhancing, where it's starting to ulcerate out, and we can see that sort of these spiculi, tendrils of enhancement, that infiltration of the buccal the buccal fat. And then here's the FDG PET that shows that this is, again, a reliably FDG avid tumor. So it can be very subtle, but you want to look for that infiltration of the buccal fat as sort of a helpful tip-off. Next is going to be our retromolar trigone squamous cell carcinoma. And so, as the name would imply, this is a squamous cell carcinoma that arises from the mucosa of the retromolar trigone. Again, that is found posterior to the mandibular molars. Sometimes people talk about the maxillary retromolar trigone. I think technically speaking, it's a mandibular feature, but it all sort of connects through that pterygomandibular raphe. But here we can see this retromolar trigone squamous cell carcinoma. Again, noting that relationship between where the buccinator and the superior pharyngeal constrictor tie together, and you can see we can get lateral or medial extension. We can get extension back to the oropharynx as well. And so note that really important relationship. Here's our anterior tonsillar pillar. We've got our buccal mucosa. We've got our buccinator muscle. We've got our alveolar ridge. So while you can get cancers that primarily originate here at the retromolar trigone, it's also a way station in which cancers in these other sites can sort of grow their way into and then start spreading in different directions. So it can make detecting the site of origin challenging, and it can also result in complex spread patterns. I'll say it one last time, that pterygomandibular raphe, this is a potential conduit of spread up to the skull base. Now, it's not like it obeys it and it strictly just funnels it through there. It kind of goes wherever it wants to go because it's cancer, it's aggressive, but it does sort of have this predilection to funnel it up toward the skull base to some extent. You want to look for things that are upstaging cancer in this case, upstaging your T category. So look for involvement of the masticator space, invasion of the masticator space muscles, as well as invasion of the bone. That's going to give us T4 disease. This is an area where I think the puffed cheek or the angled axials can be helpful to throw some of that streak artifact off of it, as well as to separate that mucosal out with the puffed cheek approach. On CT, again, I sound like a broken record. These are going to be variably enhancing. We really want to look for that bone erosion because that upstages our disease. On MRI, it tends to be T1 iso-intense, T2 hyperintense, variably enhancing, but tends to have some degree of enhancement. Look for that muscular invasion of those muscles of mastication. You look for that perifascial and potentially perineural tumor spread as well. Here we can see on this axial T1 post-contrast this retromolar trigone mass. This is kind of doing all the things. These spicules, these tendrils of tumor extending out lateral, out into the masticator space along the masseter, extending back into the infrazygomatic masticator space along the pterygoid muscles. I'm not showing it on this image, but we'll see on a subsequent slide. It's getting into the maxilla. It's growing its way back toward the palatine tonsil and the oropharynx as well, getting to the parapharyngeal fat. These are going to be FDG-AB tumors, just like all of our squames. Okay, so here's an example of how these retromolar trigone squamous cell carcinoma cases can be subtle on imaging. A lot of that, again, has to do with that beam hardening, that streak artifact from dental amalgam, really kind of obscuring all of the real estate in this area. But if you look, this one is just a little bit more hyperdense than the other side. Now, granted, it's challenging with all this streak, but it's a little bit hyperdense. Maybe there's something infiltrating there. We get an MRI. Sure enough, that's replaced this ill-defined amorphous decreased T1 signal. Compare that to the normal fat on the other side. Here's a PET MRI. This is a fused axial FDG PET MRI, and we can see the uptake corresponding with this small retromolar trigone squamous cell carcinoma. So it can be very subtle. It can be masked by streak artifact. Use these different techniques that we've talked about, these life hacks, to sort of work your way around that. Here's a much bigger retromolar trigone squamous cell carcinoma. Big, hyperdense, mildly enhancing mass. Centered in the retromolar trigone. It's working its way deep and medial into the pterygoid musculature. It's getting down to the parapharyngeal fat as well. Look what it's doing to the bone. It's eroding it. We've lost that cortex. It's getting shaggy and irregular. It's right along the inferior alveolar nerve canal, so you can imagine perineural tumor spread is an important consideration here as well. Go a couple clicks higher, we can see how this buccal fat, this retroantral fat, is getting replaced by tumor. It's invading into the pterygoid musculature. And look very carefully, we can see it's eroding out the maxilla, extending into the maxillary sinus. So this is definitely T4 tumor on account of the maxillary bone involvement, the mandibular bone involvement, the masticator space involvement as well. Here's the axial T1 pre-contrast. Fat's your friend. We see the fat here. We lose the fat here. This infiltrating invasive tumor. T2. This one is not all that T2 bright, probably because this is a bit more of a cellular or fibrotic tumor at presentation. So, I've heard a lot of people say, oh, I don't need to do diffusion imaging because I'll just use my T2. Well, sometimes the T2 really just doesn't show it as well, and you can't, I guess you can assume that, hey, this must be really cellular because it's dark enough on T2 that I'm just not seeing it well. Here's our contrasted study, and we can see this nasty spiculated tendrils of invasion out laterally into the masticator space, medially into the masticator space, into the parapharyngeal space, invading the maxilla and mandible. Big fan of diffusion imaging. Here's our diffusion trace, beautifully mapping out the extent. See these spicules, these tendrils of invasion? Really nice at mapping where the primary tumor is at. It's relatively dark on the ADC map because it's a cellular tumor. We can see on this coronal T1 just the full infiltrating extent of this T4 tumor here. Important, we also see a level 1B lymph node. It's hyperenhancing, it's rounded, loss of fatty hilum, metastatic lymph node. confirming that as expected on this coronal FDG PET CT as well. So trying to drive home the point, multimodality imaging is quite complementary in staging. This is a good example of that. All right, hard palate squamous cell carcinoma. This is squamous cell carcinoma arising from sort of the roof of the mouth. Can be very, very easily overlooked. I think it's really key that you look at the coronal plane. It's probably the only sequence you're going to see it on, or the only series you'll see it on. These oftentimes present with painful ulcers and a mass, kind of a common complaint that you'll hear with this, as well as alveolar ridge squamous cell carcinoma, is a patient whose dentures are no longer fitting. This is going to be the least common site of oral cavity squamous cell carcinoma. In fact, if you look at masses that originate in this location, statistically speaking, it's more likely that a hard palate tumor like this is going to be of minor salivary gland origin than a mucosal squame. But sometimes we do see it, as this really highly aggressive case that I'm showing you here is. This is a time that we want to be paying close attention to those greater palatine nerve canals and the pterygopalatine fossa due to the risk of perineural tumor spread. So as I said, maybe not this case, but most of the time these are pretty subtle, easily overlooked cases. You really need to know where to be looking, so it's critically important to read clinic notes. On CT, again, variable enhancement, but we want to look for bone erosion. Here we can see big time bone erosion, eroding out the hard palate, alveolar ridge. Presumably, we have tumor extending into the nasal cavity and the maxillary sinus. On MRI, use the coronal T1 pre-contrast without fat saturation. We want to look where that fatty marrow is getting replaced by tumor. We want to see that loss of bright signal, so don't fat saturate your pre-contrast T1 series ever for the head and neck. Variably enhancing tumors reduce diffusivity due to their cellularity. Reliably FDG avid. You've heard the spiel before. All right, here's the patient on our contrast enhanced coronal CT. Gigantic lobular mass rising along the hard palate. We can see how it's eroding out the bone, presumably protruding into the nasal cavity and the right maxillary sinus. T1, we can see just a little bit of that normal fatty marrow of the hard palate out laterally on the left, but it's all being replaced by this infiltrating tumor. We give contrast, it enhances, but not as much as the sinonasal mucosa. So I think looking at the sinonasal mucosa, which should ordinarily enhance brighter than tumor, can actually be helpful for tumor mapping. We like to think, oh, it's a tumor, it's going to enhance avidly. Well, it does relative to many structures, but not the sinonasal mucosa. So one of the tenets of head and neck imaging is these tumors oftentimes don't enhance as avidly as the sinonasal mucosa, and you can really nicely trace out the borders of this tumor where it's sort of plastered up against the more avidly enhancing sinonasal mucosa. FDG PET, no surprise, we've got, FDG avid, hard palate, invasive mass. Now, as I said before, don't forget about perineural tumor spread. Same patient. Take a look at that right pterygopalatine fossa. It's getting replaced. That should be fatty, like here. It's not. It's got infiltrating intermediate tissue, signal tissue within it, and it's widened. Now, if you look very carefully, this patient also had a bonus skin cancer that I'm trying not to draw your attention to with arrows, but for the eagle eyes in the audience, you'll see, yes, this unfortunate patient also had a big skin cancer. That perineural tumor spread avidly enhancing, you can see nicely on this axial T1 post-contrast with fat sat, and again, big heinous bonus facial skin cancer as well. So just beware of perineural tumor spread from the hard palate squamous cell carcinoma. The greater palatine nerve goes north into the pterygopalatine fossa. Once you get there, you can have spread into the sinonasal cavity, out into the masticator space, into the orbits, or back intracranially. And to wrap things up, I will talk ever so briefly about minor salivary gland carcinomas because they do get staged the same way as these oral cavity mucosal malignancies. So there's somewhere on the order of 1,000, maybe 800 to 1,000 tiny mucus or seromucous tubuloalveolar glands within the submucosal head and neck. You can see they're found really all over the place, but the oral cavity is one of the places where we get a lot of them. So be on the lookout for potential tumors that originate from minor salivary glands. So minor salivary gland malignancies are fortunately rare, and they're sort of a bunch of heterogeneous different histologies. Their clinical behaviors kind of vary depending on the histology. But these are staged differently than the major salivary gland tumors, as I mentioned before. We stage these as though they are a tumor that originated from the oral cavity mucosa. Now, one of the things to keep in mind, just in general, the smaller the size of the salivary gland, the more likely a given tumor arising from it will be malignant. So minor salivary glands are the smallest. High likelihood that these are going to be malignant tumors. So anytime we're dealing with these tumors of the oral cavity, these are the same kind of spiel. We want to look for features that upstage disease, and we want to look for perineural tumor spread. So this is a case in which there's a fairly circumscribed lobular mass along the right hard palate. We can get the sense that it's sort of excavating and remodeling out the bone, sort of intermediate attenuation on CT. Obviously, something like this, we want to get an MRI. We can see lobular sort of T1 intermediate signal intensity mass, maybe sort of fairly circumscribed margins, maybe not the most aggressive thing in the world. It enhances, but not tremendously, so sort of mildly enhancing. It is T2 bright, and again, lobular, sharp margins, but it's not light bulb bright. It's got some areas that are a little darker in its signal intensity. Here's the axial T2, again, relatively circumscribed, but heterogeneously increased T2 signal, again, with some areas that are a bit darker. Well, interestingly, the ADC map is not light bulb bright. So, if you had something that was lobular, circumscribed, T2 bright, put it in the middle of the parotid gland, we might be thinking that it's a pleomorphic adenoma. Well, these are minor salivary gland tumors. Can you get pleomorphic adenomas? Sure, but it's more likely to be malignant. Just knowing at baseline the likelihood of malignancy is high. And then also look at the ADC map, relatively dark. Darker the ADC, the more cellular, the more likely to be malignant. This ends up being a polymorphous adenocarcinoma. Not something I'm putting in my differential. The pathologist needs to tell us that. I just talk about the features that are useful for staging. In this case, convey to them that you think there's a chance that a reasonably high chance this is malignant due to just the overall appearance, but B, the fact that it's ADC dark and as a cellular tumor. So with that, I'll wrap things up. I think it's really important that you know the normal anatomic contents of the oral cavity, as well as its anatomic relationships with the sublingual and submandibular spaces, because everything is so intimately involved and interconnected here. Hopefully after watching this lecture, you'll get a sense that CT, MRI, and PET are really complementary in the evaluation of oral cavity cancer. They all have, to some degree, strengths and weaknesses, and so you can put them together and really kind of put your best foot forward in terms of most accurately staging these cancers. I think it's really important that you're familiar with all of those common subsites of oral cavity cancer. And then, as always, you want to look for and report features that are going to upstage the tumor so that the treating teams know how to be appropriately aggressive with their management. So with that, we've sort of reached the mountain of this talk. I appreciate your attention, and hopefully you'll get something useful out of this and can apply some of these strategies to your imaging of patients with oral cavity cancer. Thank you so much.